Hello, Gaur Wajid, Professor Gaur Wajid. Good afternoon to you from London. How are you, sir? It's a very important subject, as you know. I mean, you've been very keen to talk about this, and I think a lot of people believe that interprofessional education is vital for getting the patient care that we need.
You see, from the WHO perspective, there are three things that set the direction of health professions education globally. The very
Mm.
first and more foremost important thing is community-based or community-oriented education. Any education that fulfill the needs of the communities. Then we come to the strategies, and two strategies are very important. One is that competencies must be defined and outcomes should be clear. And this should be done through interprofessional education and collaborative practice way. So that's the approach. This is why community-based education with well-defined competencies through interprofessional education and the use of digital technologies. This
So,
is the crux of education from
can I
WHO
interrupt?
perspective.
Can I interrupt you here, Professor Gaur Wajid? We'll
Yes,
start the
sure.
podcast, and we'll benefit with the experiences from WHO point of view. That will be on behalf of Sadiq International Virtual University and ERA, its very close affiliate, partner, collaborator. So the floor is open for a wonderful interactive podcast on a subject which is close to everybody's heart. All educators agree on this point that of all the things that you mentioned, interprofessional collaboration is vital for getting the goals of giving the best of cares to the patients. So over to you, Anuja. You can take over and start. Thank you.
Thank you so much, Zaidi sir. A very good evening to all the participants and greetings from India. On behalf of ERA University and CIVU, we take this opportunity to welcome you to this enlightening webinar, Interprofessional Education, Tips for Design and Implementation. This is presented on behalf of our Honorable Pro Vice Chancellor, Dr. Farzana Mehndi, my mentors, Dr. Sucheta Dandekar Madam, Dr. Nirmala Madam, and myself. So good evening, ladies and gentlemen. We resume with this. I would like to start the presentation with the acknowledgements first, because it is the mentors who lead you where you are. Once again, Dr. Farzana Mehndi ma'am, Dr. Sucheta Dandekar, Dr. Nirmala Regge ma'am, all my mentors and peers of my parent institute of interprofessional education at Manipal Mahe, and my team members at the ERA University. The learning objectives for today's session are: we will be defining interprofessional education, understanding its significance in healthcare, describing the key principles and competencies of interprofessional education, describing briefly the teaching learning methods for implementing IPE, discussing ethical consideration while practicing IPE, and most importantly, discussing tips for facilitation of interprofessional learning and building of positive team function. I would take a moment for all of you. You can use the chat box, and my mentor, Dr. Nirmala Regge ma'am, will help me with this. Think in your minds, what do you think of interprofessional education? And if you are already familiar with most of us are, how do you think we can incorporate interprofessional into the curriculum? And what difference do you expect once interprofessional education has been incorporated into the curriculum? So I'm just counting till 10 till you are able to type in a few things in the chat box.
Requesting all of you to please type.
It will help us bring in the true spirit of interprofessional education when we learn with, from, and about each other.
Yeah, Mona is writing, IP is when students of two or more healthcare professions study together from each other and about each other. It is also mentioned by Vishnu Mukalla, teamwork. Yes.
Okay, thank you so much, ma'am. So I think a few words which come into our mind as we think of interprofessional education. We think we are talking of two or more professions. We think that we are learning together. We think of teamwork. We think of collaboration.
Yes, collaboration is also mentioned by Yogesh, collaboration between different fields of medicine.
Thank you, ma'am. So these are few words which have come into our mind. But friends, we will take you a little more beyond into the journey. As you see in the picture, we see the picture of some secluded, isolated tanks, as called as silos. When I was introduced to this concept of interprofessional education way back in 2018 in a national conference in India, the first terminology was interprofessional education is breaking silos. What does that mean? We as healthcare professionals have become accustomed to practice in compartments. The ENT surgeon is sitting in the ENT OPD, the ophthalmologist is sitting in the ophthalmology OPD, neurologist in the neurologist OPD. And we intend to treat something together, something like headache, but we cannot do that till we know that we have to break the silos. So breaking these compartments, not only in the terms of actuality, but it is breaking your egos to come together for the delivery of healthcare. With this concept, WHO says interprofessional education is a necessary step in preparing a collaborative practice-ready health workforce that is ready to handle the local health needs. I'm having again a problem in moving.
Jazakallah, sir. Thank you so much. Well, I would say that interprofessional education from WHO perspective has been at the mainstay of educational reforms. And when we talk about IPE, CP, this is where most of the discussion today in this seminar would probably take place at what we call the macro educational reforms level at the highest levels of the strategy. For example, there are 612 medical colleges in India alone. And when we talk of IPE, then from the national perspective, from Indian Medical Council perspective, the question would be how to design a curriculum that incorporates interprofessional education as one of the features. So that's how massive the task, the grandeur of the task is for the imagination of the audience. And this is just from Indian perspective.
Thank you, sir. We will be sharing our experience of how we have been able to do that successfully. I think I should be able to share the slides now. Are they visible, sir?
Yes.
Yes. Please.
Yes.
Yes.
Yes. So thank you. I resume again. And thank you very much, sir, for your invaluable words. I think COVID has been one of the landmarks which has made us understand that we cannot treat the patient in silo. When you treat the patient as a healthcare professional. Also well said by Arden. He put this line that COVID had a silver lining, and the silver lining was that we were able to understand the true meaning of teamwork and collaboration and prepare the future healthcare teams. So I would be using two slides as a foundation. Way back in the 1980s, it was the Institute of Medicine which came up with the concept of educating the health team, followed by the Center for Advancement of Interprofessional Education, UK, in 1987 published its statement and principles of interprofessional education, which said that it is when two or more professionals learn together intending to cultivate collaborative practice. As said by Sir very rightly, WHO says, when students from two or more professions learn with, from, and about each other for effective collaboration, that is where you have interprofessional education. Ladies and gentlemen, I'd like to draw your attention to the board which says interprofessional. Interprofessional is one word, true to the spirit of interprofessional practice. When you have interprofessional education happening within the curriculum, it leads to interprofessional collaborative practice, and of course, an improved healthcare delivery system, which is depicted in this particular figure. In other words, the need of the hour is that we need to understand the importance of designing and implementing interprofessional education modules right from the time of the pre-licensure, so that the team which is prepared for tomorrow knows the importance of interprofessional collaborative practice. So what do we get in turn of that? We get improved patient safety, less medical errors. We're able to handle complex health needs with successful patient management and collaborative practice. This is another picture which has been used by the definitions of the interprofessional collaborative, which tells us that the system of generating interprofessional collaborative practice teams is going to be directly impacting the need of the healthcare system. In other words, different societal needs are now in need of a healthcare force which can work in teams. So what do you need to work in teams? I think most of us here in this webinar today, including myself, we were never trained to practice in a team. We were always told, of course, with improved teamwork, with improved collaborative practice, we should be able to get an improved outcome. Yet my patient of headache, my patient of vertigo goes from one clinic to the other without getting the true collaborative need. And that is when we realized that this is the time where we need to put it into practice. And we started taking our small steps. The four important pillars, as Sir said, of interprofessional collaborative practice are, as we say, this is a single domain, ladies and gentlemen, interprofessional collaborative practice. Now imagine this single domain having four important pillars. So we are looking at four important competencies, which we in true sense are already practicing. We understand communication is needed. We understand teams and teamwork is needed. We understand roles and responsibilities. We understand values and ethics. But stop for a moment and think, whenever you are delivering healthcare service, do you know your colleagues' roles and responsibilities? If I am doing an epistaxis packing, do I know what are the roles and responsibilities of my nursing colleague, my trauma technician colleague, or my counselor for that matter? No, it's only myself that I am treating this patient. But we need to understand, to come out of our silos to deliver interprofessional collaborative practice. As we delve into the competencies, we need to understand that whenever we have a team coming together, it could be anybody. For example, if we are looking at treating a patient of hearing loss, please excuse my common examples from the practice of ENT, because by profession, I'm an ENT surgeon, and so relatable to Zaidi sir, that when I talk about hearing loss in an elderly gentleman, we have a lot of professions. We have an audiologist, we have a speech therapist, I have a dietitian, I have a counselor, I may have so many. But here we need to understand that there are a set of competencies which each of us possesses. Now, so there are individual professional competencies. So I would be able to diagnose, I would be able to give the pathophysiology of hearing loss, But what about my audiologist? My audiologist can also carry on the examination of the ear, carry out the audiology, understand the pathophysiology. So we have individual professional competencies. We have a few common competencies. And then we have a set of the interprofessional collaborative competencies. And friends, these are the competencies that we need to develop. Now, I would be just mentioning a line about each of the competencies before we go on to tell you our examples that which we have been able to implement interprofessional collaborative practice. We understand values and ethics is working with team members to maintain a climate of shared values, ethical conduct, and mutual respect. Roles and responsibilities use the knowledge of one's own role and team members' expertise to address individual and population health outcomes. Teams and teamwork apply values and principles of science for teamwork to adapt one's own role in a variety of team settings. And interprofessional communication, which I feel amongst the 4 competencies is the most important. Communicate in a responsive and a responsible way, respectful and compassionate manner with team members. These are not competencies which I'm coming to now, like collaborative leadership and patient-centeredness, but yes, they are an important part of interprofessional collaborative practice. Now, once we have understood that yes, interprofessional education is much needed, we need to have an interprofessional education module into our curriculum. We need to implement it for interprofessional collaborative practice, to have a team who knows to work with, from, and about each other. But how do we start? So for all our colleagues, and being the interprofessional ambassador for the ERA University with an interprofessional cell, when we have colleagues joining us, we ask them for the problem identification and needs assessment. Talking of the city that I live in India, at the moment we are facing monsoons and we are faced with a common problem of mosquito-related diseases, which means I'm looking at vector-borne diseases like dengue. Now, am I prepared to handle an epidemic of dengue in my locality? Can I do that alone as an ENT surgeon or as a physician? No, I can't. I need my stakeholders in place. I want all of them to contribute to take the adequate preventive measures. Now, for my team to understand, for a resident in medicine, I need to understand what would my targeted needs assessment be? What would my goals and objectives be for that IPE module? What will be my educational strategies? How would I implement it? And my evaluation and feedback. So the first step when you decide to implement an interprofessional education module for your respective curriculum, first understand that what is the problem identification, and please do the needs assessment. For example, when we started off with our project, the first thing that I thought in my mind is, I thought that it is the patients of tracheostomy where I think I much needed the collaborative care. And this question came to my mind because when I used to do my tracheostomies and I used to finish and go off from the ICUs, and I came the next day, I found that my colleagues were not able to take care of the patients the way I expected them to do it. The end result was I could not decannulate my patient at the right time. I could not shape my patient in the post-operative without the tracheostomy tube at the time I had thought. So I realized that if I wanted more improved care, I wanted a more confident relative of whom I had done a tracheostomy, I needed to understand how to do tracheostomy with interprofessional collaborative practice. Now, with this, we talked about, for our Mahe Fama project, we conceptualized a project for interprofessional collaborative practice module for tracheostomy. Ladies and gentlemen, this is our team of having my physiotherapist colleague, my nursing colleague, the head of my OT and trauma technician team. And we decided, first of all, first question, and I would just like to draw your attention, this was in the period of 2020. We were right in the midst of the pandemic. We were all in a turmoil physically and emotionally because our hospital was a tertiary care center for COVID patients, where we were having patients in the ICU in whom I had performed the tracheostomy and who needed a true interprofessional collaborative practice care. So with this, we set on to make our IPE team. We decided who the stakeholders would be, including our statistician, our management, and we started doing our strategies for an improved implementation. We decided to make a module, and this module set out to have its objectives, teaching learning methods. We had a validated questionnaire for training and assessment, and this questionnaire was based on the McMaster Ottawa scale, and we divided it into 3 parts, not relevant very much to the non-ENT people. We had a pre-tracheostomy, tracheostomy, and post-tracheostomy. We validated it within the institution and from beyond the institute, and it was validated by all professions. Means this questionnaire was validated by physiotherapists beyond ERA, it was validated by nursing staff beyond ERA, it was validated by ENT surgeons beyond ERA. And we were able to carry out this. It was done initially for 25 students. We carried it out. We faced many challenges of time management. And of course, a huge hindrance which we faced was, I think, an emotional challenge, because in the midst of it, we had students who were posted for COVID duties, who had to come and perform this module. But it gave us a new sense of confidence. It told us that we can do it together and we would be able to reach where we had decided to set in. And we were able to successfully complete the module. We have even published it in the Indian Journal of Otolaryngology. We wanted to take it a step ahead, and we decided to make it a part of the institutional curriculum, for which we followed a step-ladder approach for the effective curriculum implementation of the IPCP skills module. At the moment, this is done for tracheostomy, and now we are taking it forward for other life-saving skills, such as a CPR. Before I move on to the teaching learning methods which we can employ, these teaching learning methods we have already come up with. We understand the true teaching learning methods which are there. There are 3 important methods which we can have. We can have physician shadowing, we can have team-based learning, and we can have community-based learning. Both these terminologies we are very familiar with, we may have employed, but I would like to share experience of how we have been able to do that. I will be going back to this. During the Indian government has a system where we have different days which are celebrated as awareness days. For example, glaucoma day, we have a malaria day, we have a hearing loss day, a balance week. So we set on to the journey. And we decided that we will form an interprofessional team. Once again, the ENT surgeons, the audiologist, our OT technician staff, our own staff, the technical staff, and a very important group of people here, the medical students. These medical students were a part of our interprofessional team. And we decided to take it on to the community and celebrate this as an interprofessional collaborative practice day, where we did a Nukkad Natak. There was a school close to our hospital. We did a Nukkad Natak with the MBBS students, trying to get them involved with collaborative practice. We carried out a screening camp where the students were as equally involved with us as we were together. And we were able to implement true spirit of interprofessional collaborative practice. So here we have many teaching learning methods which have been employed together. You have physician shadowing, you have a community practice. So you have a sense where interprofessional collaborative practice can be taught with an amalgamated method. And as it says, together we all achieve more. I would take a moment to take you to the journey of the tips which had to be shared by my senior colleague, Dr. Suchita Dandekar, madam, for reasons she's not been able to join. So I will be sharing some of the tips which she was able to mentor onto me. These are already the competencies which we have talked about in detail.
Okay.
So we would, can I, ma'am, you said something?
No.
Thank you so much, ma'am. So these are certain tips which Suchita madam keeps talking to me. And if many of you would have met madam in her sessions, her vibrant self actually helps you overcome the challenges. An important point, whenever as family scholars or as collaborative workers, we decide to implement a new part into our curriculum, we are faced with challenges and we already understand the theory by Kurt and Lewin, where we have theories which you have certain forces which help you, and there are certain forces which refrain you. And you have to develop strategies in which you are able to overcome these refraining forces and accelerate those forces which are helping you. Whenever you implement an interprofessional program, you will be faced with challenges. You will have people coming to you telling you that you're short of time. You have to match the schedules of multiple professions together. You may be having a problem where you may need to fit this module into a space. For example, for the tracheostomy module, our experience, we had the group of postgraduate ENT people here. We had bachelors from nursing, we had bachelors from the OT and trauma technicians, and we had bachelors from physiotherapy. Ladies and gentlemen, till you decide to do collaborative practice, it is important that that particular skill that you're talking about has been adequately covered in your respective profession. For the ENT surgeons, you realize to do a tracheostomy only when you have come into the post-graduation. So you have different levels of students who are coming together, breaking their hierarchies and learning to work with collaborative practice. So the tips as shared by Madam are there. Of course, you should know the role of other professions, questioning, focusing on the need of patients, trust, most important. You can employ a flipped classroom approach, be a facilitator, not a lecturer, peer learning, review and reflect, assessment and feedback. These are again the themes of IPE, which Madam wanted to emphasize again, that how you will be able to implement these themes and overcome the barriers. Of course, common barriers for effective teamwork include, we need to overcome the barriers of the communication skills, differing professional cultures, extremely important, traditional hierarchies and assumed leadership, role blurring, confused over boundaries and responsibilities. I faced an immense challenge in that. I had challenge because till I started my journey into interprofessional, it was only I had one identity. I had an identity of just an ENT surgeon. But I realized that I'm not just an ENT surgeon. I'm in true spirit just an healthcare professional. And that's where over my journey, I'm still developing my dual sense of responsibility. So most importantly, once you have put your program into space, you need to evaluate your program and understand how successful you have been in your journey. With this, I would now hand over the platform to my senior colleague, Dr. Nima ma'am, taking it over. Ma'am, please.
Yeah, I will be discussing mainly one of the competency, and no, the most important thing is that the underpinning this IP is the ethics, and all we know is the ethics is for correct behavior. It should be dictated from within and own moral integrity. But every profession has a code of ethics. That means these are the statements which are with a set of rules based on the values and standard of conduct to which the professionals of a profession are expected to conform. And there are these guidelines provide us a framework how we are expected to behave in different situations for making ethical choices and to reflect the values of the profession. So next slide. Anuja.
Ma'am, allow me a minute. The slide is not moving. Ma'am, I'll have to, I think, stop and share again, ma'am.
Okay,
It's
then
not-
otherwise I will share from my platform.
Sure, ma'am.
Yeah, just Okay. Um, so, all of you know that when we talk about any profession, we talk for any profession to have professionalism is very important. And I like this the particular slide, which is by Stone, who has given the model. And as you see over here, the foundation is laid by not just the clinical competence or the communication skill, but it is an ethical and legal understanding. And then there are aspirations of too, and one wants to go to the excellence, humanism, accountability, and altruism. But the ethics is very, very important in it. So these principles of ethics, though there is a code for everyone, and these codes have come since long time compared to this Belmont report, which was in 1974, which stated the cardinal principles of ethics, basically in the research, that is to protect the human subject in the biomedical or behavioral research, its respect, beneficence and non-maleficence, and the justice. But the same principles also apply when we are practicing, and they are still important today when we are discussing any ethical issues, as we will see later on. And what they stand for? The respect for persons, that is autonomy of the individual, the rights of the individual, the special protection for those who have a diminished autonomy, like we call it as vulnerable population. Beneficence is the maximization of the possible benefit, and non-maleficence is minimizing the possible harm. And justice is to act equally and fairly while providing health care and the equity. Little bit about the individual thing to understand how it is important in IP later on. That this autonomy is, as I said, it is respect for the rights of person to make healthcare decisions. So to incorporating in the healthcare decision, the shared responsibility, the commitment to include the patient in the decision about all aspects of care, and then taking informed consent, confidentiality, maintaining confidentiality, and truth telling, and that is veracity. Beneficence is not just related to the disease, that of course the physicians are working for that, but it is for the health. And then it is a health promotion, providing compassionate care, and it is at the level of individual, family, society. And when we talk about the health, we always talk about not just the physical health, but it is social, emotional, spiritual well-being. So improvement in the quality of life. And all this is thinking about the financial benefit to the patient and not to a self. So all our personal things and all our fame, etc., when we are talking about the beneficiary, they don't have any priority. It is mainly the accountability towards our patient. And then do no harm. That is the most important aspect which is included as a part of the beneficence, that is avoidance of the harm, which could be physical, which could be psychological, which could be moral, which could be socio-economic. So one has to have always the balance between benefit and harm. And there many a times the ethical dilemma starts. And there is an emphasis for the need of fair medical competence, attention to the care and safety of patients, and capacity to evaluate the risk to patient. Without that, we can't decide what is to be given. And justice is, as I said, providing the healthcare irrespective of the caste, religion, social status, gender, race, you name, educational status, or other opinions, options, and opinions, and aligning it to the principle of benefit so that this will help to maximize the benefit. At the same time, when we are working in the hospital, we find there are a lot of resource scarcity, and then allocation decisions they come, which will, to whom it should be given. And as you see in this particular diagram, we don't go by the equality, giving everything equally to everyone, but we go by the equity, because not everyone has this same need and they don't stand at same place. So one has to keep in mind. Now, there are problems when we are practicing with this ethical understanding. but it is mainly between one individual physician and the patient. But when you are practicing interprofessional practice, you can see there are many times this violation of principles go. And as Anuja said, that can happen in surgery, like she said about the tracheostomy in the theaters. It could be in ICU, it could be family medicine. And then many a times it happens that we are not respectful to the other profession. She mentioned about hierarchy. So the medical professions, many a times they take the decisions because ultimately the responsibility of decision lies over on them. But sometimes there could be a detrimental effect of the hierarchy because they may not be knowing all the aspect unless they communicate with each other. And there could be the violation of the beneficiaries. It may be treating someone differently when you are working in the team, violation of justice. And then there could be communication problems. Even while talking, you may make a remark, that's my opinion. But remember, though it is adherent to the principle of veracity, being honest, you can be at times brutal honesty. And there that may hurt others, and that could be a psychological hurt, not a maleficence. And questioning others' opinions, that someone says something or gives the opinion, you are every time questioning and you are not sharing what is your opinion. So the other person can't understand it. And there could be disagreement on the decisions because there is a team. Everyone may have different profession, may have different decision where to discharge the patient, or sometimes the decisions for withdrawal of a particular treatment. And because many a times it happens, the medical person thinks about the legal aspect and all those things and takes a unilateral decision. So that becomes violation of the autonomy of others' rights. It may happen when you are working in the team that you are criticizing the personality characteristic of a team member. The team member may not be there, and then it is to the level of gossiping. So this is a violation of that non-maleficence. And you become judgmental if you feel that the team member does not conform to the ideas or values. And these values, though basic values are same in all professions, there could be differences in some of the values, some of the cultures, and you don't understand it. Some people may try to go beyond, according to their professional boundary, and they don't like to socialize. And some people may like to socialize. That is individual decisions. But the group may criticize that, and someone who is not socializing well beyond the professional thing, that may be criticized and sometimes even behind the back of that person. So whenever there is a team, the members join, members leave the team, new members come, and when the new member comes, it happens that you compare that member with the previous one, and which is also not correct. And you don't give the chance to the new member to get absorbed into the team. And sometimes some people have a habit of saying some negative things about patients and their family. The people who are with the patient for a longer time, they know the family matters. They are seeing those patients day in and out. But talking negative things, is not the correct thing. There could be diversity, as I said, in the values and the culture. And many a times, even at the organizational level, there is a non-receptiveness, or you can't depend on the organization to support you. And many of these things can give rise to negative outcomes also. And there are good references which you can go and look at them. So what happens in the interprofessional practice, apart from in the individual profession, it is not just the individual physician and patient. There are other professionals also. They, as Anuja said, they have their roles and responsibilities. We are not aware of that, but they also have something. They also have connection with the patients, and they have those ethical roles with them. And most importantly, the organization, all of the team, they are also there have to conform to the organizational ethic. So it is not a single person, it is an individual, it is other team members, and it is organization. And we have to view the ethics from that. And ethics can't be taught in as a vacuum. Everything is happening in a social context. So we have to take into consideration that also. And therefore, the interprofessional values and the related ethics are not just only patient-centered or with community and population orientation, but they should reflect in reality that collaborative care is taking place. There is a commitment to create safer, more efficient, more effective systems care, and this is a shared risk commitment and not the individual commitment. There should be respect for others' roles and responsibilities. There should be mutual understanding of value differences among health disciplines, because we know about our code of ethics, we don't know about others. And there is something as a communicative ethics. And we have to, while talking or while explaining, while communicating, it may be verbal communication, it may be non-verbal communication, we should follow those guidelines. And one should there are various situations where the conflict can occur, but constructively confronting with the conflict, because otherwise there is a team's ability to work effectively becomes lowers down, and it is difficult to solve the clinical problems, which are very, very complex at times. And there should be a culture of inclusion whenever we are talking about interprofessional practices. And that's why the core competency of IP is to work with individuals of other professions to maintain the climate of mutual respect and shared values. And then these competencies again divided into sub-competencies. I will not go through that, but this amongst these sub-competencies, one should remember the fourth one: respect the unique culture, values, roles, and responsibilities, and expertise of other health professions, and the impact these factors can have on the health outcomes. So, whenever we are having the interprofessional education, one should pay attention to that. Now, when we are applying it into practice and when we want to address it to the ethical issues, then, as I said, there should be three levels: individual, team, and organizational. And Clark et al. Has developed interprofessional ethical framework. So they have considered these three levels, as well as they have considered three components. One is the general guidelines for the behavior. So that should be for a IP, considering whatever I have discussed earlier. There should be some established forms of knowledge or expected pattern of behavior. What is to be done at a given situation? And what are the actions that play? What is to be done is one thing, but how the things are done, that is another thing. So general guidelines, structures, and process. And in their article, which was, though it was published in 2007, they have given a beautiful description of how these three things can happen. And at individual level, team level, and organization, what is expected as a general guideline, what is expected as a pattern, or what expected behavior, and how those things can be tackled. So I request all of you to go through this properly. What I want to emphasize is as whatever is mentioned in the same article, that one of the major reasons that many clinical teams do not survive over the long term is that these principles, structures, and processes are not put into place to address the ethical issue that inevitably arise. So these issues can occur. For example, in ICU, withdrawal from the treatment, when to withdraw the patient from the ventilator. There are so many issues are coming up. So all these three things should be seen. And therefore, true interprofessionalism is much more than putting nurses and physicians in the same workplace or educating dental students and medical students in the same classroom. The true interprofessionalism have foundation of this shared ethics and values. And the entire issue of AMA Journal of Ethics, which was published in 2016, is devoted to this. And I'm just telling you about the editorial, which was written by Dr. Farrell for that. And one thing which has happened, therefore, while in this interprofessional education, people have means many faculty members and institutions have thought that why not teach ethics in an interprofessional as an interprofessional education. And there is an article which was published in 2005, which they have found out what are the major topics to be taught in ethics. What are the common ones, like ethical theory or professional duty of care, code of practice and accountability, informed consent, confidentiality, vulnerable patient, research ethics, and rationing of the resources when there is a resource consent. So what should be followed? And later on in 2019 and 2022, these are the two articles. They have used this ethics and the interprofessional education programs to teach the ethics in the classroom based, and they use the narratives or the problem based approach, and they have given their own experiences for that. And I think this is very, very important. It may not be possible for all of us to suddenly change into the entire curriculum into the interprofessional one, but we should try to find out the places where we can bring this interprofessional education and what benefits it can have. Like Anuja tried for her tracheostomy, she's trying for CPR. One can try for the ethics as well. Yes, Anuja, can you? Hello.
Thank you so much, ma'am. And once again, I had a learning experience with me. You have been my mentor all through. And ladies and gentlemen, I'd like to share here, it is indeed a absolutely emotional moment, because it was ma'am by my side who had uploaded my FAMA project with me, which was subsequently accepted. And it has been a long journey together. I would like to put a question to the esteemed audience here. I was almost typing it. What are your experience as far as interprofessional education and simulation practices are concerned? Gohar sir, I would like your view for this.
Thank you so much, Dr. Anuja, and what the other presenters for wonderful oversight
Dr.
on Dr. Nirmala and other presenters. This was a wonderful presentation on the overall view of interprofessional education. A couple of just my reflections, where the educational community has seen, despite the development of the concepts and a common agreement that the curricula should be based on the concepts that have been presented in this particular talk. But my question to what the audience, all audience from their experiences is, why the countries and the regulatory bodies have not been able to make a progress at a pace that is required to bring reforms in the curricula that are really needed. I will give you one example that will help you to ease out the question. When we started hearing about community-based education, there are no true differences of opinion that all curricula must be community-based. When we asked the regulatory bodies and the decision makers how much you have succeeded in making your curricula community-based? Answer is usually not that encouraging. Same applies to competency-based curricula and interprofessional education-based curricula, where despite agreement on these concepts, we have not been able to incorporate these concepts in the development of one curriculum. That still yet I have to see a medical college where the principal of the college says, look, my curriculum is community-based. It is based on competencies where all competencies are clearly defined, and it incorporates elements of interprofessional education as well. And the most common answer or the caveat or the challenge I get from the worthy experienced participants or experienced experts is that the cost of implementation of these concepts is very high. So I would rather like to hear from your experiences on what do you think on how to transform our curricula into based on these concepts.
Thank you, sir. Thank you for this absolutely valuable question, and it's a challenging thought. I think, sir, we have a hand raised here by Dr. Mohammed Abdul Zahra. Would you like to share, sir? Sir, you have to say
Thank you very
something.
much. Thank you very much. My response to our colleague, Professor Gohar Wajid. I think the stakeholder, they are either they don't know or they are not have not the will to do this change. I was the dean of Kufa Medical School, and I was keen to implement interprofessional educations, but I have no authority to bring the student from the College of Nurse or College of Pharmacy. So the university should do that and should gather, and we try our best. We do a trial of workshops between 10 students from College of Pharmacy, Medicine and Nursing. It was very, very useful workshop, 3-day workshops. At the end of these days, a student from these colleges realized that the importance that there is a limit for each profession, and there is a sharing things between these professions, and working together is very, very, very useful. But again, when we asked the president, vice chancellor of the university, it is in their job and their authority to bring these colleges. I think the answer of your questions is that either the leaders of the colleges or universities, medical universities, or the health department, they don't know or they are not keen to do that. And sometimes if you have, you can't do it because you are working at the college. Thank you very much.
Thank you very much, sir. Gohar sir, I would like to add one aspect which I have been thinking about interprofessional for last almost 6 years right now. And sir, I feel that one of the questions that we always ask ourselves is, what is in it for me? So when at the people at the helm of the management, when you put forward an interprofessional module for them, and when they realize that the councils which are at the helms of affairs are telling you that it is the need of the country to implement interprofessional collaborative practice, whether it is the medical council, whether the nursing council. So once that is there, sir, I think we will have more people at the level of deans wanting to implement interprofessional programs. And it has happened in the Indian scenario. I think the most apt person who has been absolutely a pioneer for CBME in our country, Dr. Neema ma'am, she can share with us that when the guidelines were being laid down, that's when the foundation has already been placed, sir. We have roles of the Indian medical graduates where you can only do it if you have interprofessional education practice. Neema ma'am.
No, but Anuja, that is not for interprofessional education. We could do that because there were many people who, we developed with FEMER and other things, the educationalists in our country, and then they take over to the at a higher level that fight their
This is
roles in the regulatory or this thing, but not for the interprofessional. To get the different people from the different councils becomes very, very difficult. And I totally agree with Dr. Kaur that even I have not seen a single institution which following the interprofessional one.
Anuja,
Yes,
there
ma'am.
is a participant from Turkey. Let's hear, they have some experience of interprofessional education. It's in the chat
Yes, sir.
box. You like them to you
Yes,
read it
sir.
out if they can respond?
Yeah.
You
In
like to
Turkey,
learn?
we are new in IP, but for the beginning, we adopted too many scales in Turkish and we made some thesis about background. But I would like Dr. Gire, will you please, I hope I'm pronouncing this correctly. Will you please unmute yourself? Yes, can you explain this?
Yeah, hi from Turkey. It's a
Hi.
good course. Thank everybody for this opportunity for me to talk about it. We are newly working in IPCP in Turkey. I'm working in Süleyman Demirel University, Department of Medical Education and Informatics. And in the beginning, we start to work about background of IPCP with some PhD thesis, and we did some basic works, studies about IPCP, and then we translated some scales into Turkish culture because as you know, there are some differences in cultural aspect of IPCP, so it would be really difficult for spatial cultures. So at that time, we need to work about scales, Turkish adaptations, and also we have some difficulties. Maybe in the future, you will get in face with these problems because it's very difficult to organize the curriculums of medical school, pharmacy, or dentistry. You need to organize the curriculums with the in the concept of interprofessional education is so difficult. And also it's and another difficult point is it's really there are real silos in works areas, so we need to work a lot about making some differences and making some developments in quality of healthcare. So it's really difficult approach, but we have a long road working on it. In Turkey, anytime you need any help of us, we can work together in collaboration with all around the world. Thank you.
Thank you. Thank you.
Thank you so much. I
And
think
there
we
is
have another
Shama from
participant.
Pakistan.
Yes, yes,
Uh,
yes, ma'am.
We have some parallel themes in curricula to teach undergraduate level in Pakistan, but not IP practically. Do you want to elaborate on that, Dr. Shama? Shama Marshall?
Yes, hello everyone. Yes, we have some theme-based teaching like communication skills and ethics, professionalism. But interprofessional education not practically done at any level, or not even at the postgraduate level or undergrad level. So there is a lot of gap in this particular area.
Yeah. And Dr. Mona has also raised her hand. Dr. Mona.
Yes, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank all of you for the excellent and very insightful and informative presentations. Actually, I am a professor of internal medicine at the Faculty of Medicine, Alexandria University, Egypt, but I was working for some time at the Faculty of Medicine at Beirut Arab University in Lebanon. And back in 2013, the need arose for the Faculty of Pharmacy because they to have an interprofessional education based module. Why? Because they were applying to be accredited by a Canadian body, which by default requested the Faculty of Pharmacy to have interprofessional education set in place. So the need arose. So the upper administration of Beirut Arab University, they formed an IPE committee formed of the deans of all the faculties of health professions, and then they started choosing coordinators from representing each faculty of the health professions. And I was the coordinator for the Faculty of Medicine, of course. And then we started designing the curriculum. It was placed in spring of every academic year. We started off by case-based presentations where the students sit in interprofessional teams in a roundtable manner, trying to solve a written case scenario of a patient involving all the possible health professions included, and then trying to come up with the ideal management plan. But then we took it a step further. We tried to implement simulation-based interprofessional education, whether on mannequins in the skill lab or on standardized patients acting the disease itself. But the main challenge we faced was the interprofessional education module was implemented in the third year at the Faculty of Medicine, while it was implemented at the final years in the rest of the health professions faculties. So my question to Dr. Anuja was, if I remember correctly, in your interprofessional experience on tracheostomy, you included master level ENT students, right, with bachelor level students of the other health professions included. So how did you manage to overcome the discrepancy in level of maturation, level of skills, knowledge, etc.? Thank you.
Thank you so much, madam. And Ilma ma'am, can I answer this, please?
Yes, she had asked you.
Yes. So yes, madam, we did have a challenge. But interestingly, what happened was that the times that we were faced in which we implemented this module was actually the COVID times. And if, one incident I would like to share here is that one part of the Southeast Asian countries, there was a time when dental surgeons were asked to take nasal swabs for COVID positive patients. So the point is that we were actually blurring the lines. Now, the point is that when you're performing a tracheostomy, madam, with interprofessional collaborative practice, an ENT surgeon is supposed to perform the steps, but a nursing student has a different role and responsibility for which at the bachelor level he is matured enough. And all of them, even if they are bachelors or they're at the masters, they all happen to be adult learners. So we were able to overcome that with a lot of peer interaction. And more importantly, when we were sensitizing them for this concept of interprofessional education, that was one of the reasons. And I think we were very blessed because we were able to get them motivated to that extent when we overcame this challenge. Because you need to understand where tracheostomy is placed in your curriculum. For example, in the ENT surgeons, I need an ENT person to go and do the tracheostomy, to perform the steps. That he's able to do when he's in the postgraduate program. But a nursing specialist, if he or she is assisting for the tracheostomy, she can do it even at her final level of bachelor. So that is when we have actually put it within the institutional curriculum, that's how we are doing it. So for any interprofessional collaborative practice module to be in place, the respective skill has to be covered as a prelude within your own curriculum. And we are using it to a large extent with simulation, because even when we go to different levels of simulation, the initial simulation is that we do it in isolation, then we do it within the clinical scenario, and then finally we are able to take it to the level of team. So that is sim zones, and that is how we have developed our interprofessional simulation lab as well. I hope I've been able to answer the question to some extent.
Yes, thank you very much.
Thank you so much, madam.
So back to Dr. Gohar, sir. I don't think anyone could answer the question you have asked, but would you like to shed more light on it?
Thank you so much, Dr. Nirmala. Two reflections I would like to make in the meantime. Number one, some of you might have read AMI Guide number 169 that has been published about two months ago. Just it's a very recent publication by my old-time friend, Dr. Professor Sumaya Husni, and her husband, Dr. Yasir. So I specially traveled to another city, Ismailia, which is about 1.5 hours of distance from Cairo, where I'm residing, to congratulate them and discuss how did they come up with the idea and how long it took them to publish that AMI guide. You know, these guides are published in Medical Teacher and they are rated of very high value. She shared the guide with me, and I would be pleased to share it in the group of our SIVU group for the benefit all the audience. And I learned a lot from that 2 hours discussion which I had with the husband and wife sitting at their home of it took them, by the way, 1 year just to get it published. After submitting it, it took them 1 year just to get it published. And their experiences were at the level that some of the conceptual challenges are also there that that prevent the translation of the concepts into practice. So I give you a small example. Dr. Anuja talked about simulation-based practices for interprofessional education. I remember a time when one of the persons, she contacted me to asking for the design of the new medical college they were going to build. And she said, we are thinking of building the new medical college based on problem-based learning. So the design of medical college should be based on PBL, which makes actually the construction cost high. But I requested her that if they are going to make such a big investment, it would be highly cost effective for them to base the structure of the building on interprofessionals education basis. And she did not have a clue about what I'm saying. So I told her that in my ideal medical college, there should be one library where all nurses, pharmacists, doctors, the medical doctors, and other allied health professionals should be studying together right from day one. So that will prevent them the cost of having individual libraries for the nursing college and for medical college and for this college and for that college. So when they have in the faculty of health sciences, when they have all these colleges, there is no point in having different buildings for the libraries. They should have one library. Why can't they have one simulation center? Why can't they have one assessment center? Even why can't they have combined classrooms which can be booked by the nursing college and medical college and so on and so forth? So the implementation of the concepts, I would say, primarily the leadership and strategic responsibilities lie with the regulatory bodies, that is Indian Medical Council and Pakistan Medical and Dental Council and so on and forth. Then our role as technical experts is to make easy ways of translating those concepts into practices on how best these concepts can be practiced in the real-time practical settings. Thank you so much.
Thank you. Sir, there is a question for you by Mona. Sir, do you advise to build an IP-based curriculum in a spiral way?
Absolutely. But my curriculum will not be it will not be called IPE-based curriculum. I would like to see three major attributes in my curriculum. My curriculum has to be community-based or community-oriented. It has to be competency-based as well. And it has to be IPE-based as well. So my curriculum is like a diamond that does not have different colors, but all these colors merge together to make a diamond. When it reflects, it gives you 7 colors. But I don't believe in 7 different colors. I believe in mixing those colors and creating one curriculum that is community based, IPE based, and CPC based. So
Yes.
that's how I see my ideal curriculum.
Thank you so much, sir. On Dr. Zaidi,
Yes.
final word, sir.
I mean, no final words with experts like Gawar Wajid and all of you. I'm only a humble student. I've learned a great deal. But one or two things I'd like to mention in relation to the third aspect of the triangle of education, that is ethics. I'm so glad that you took it up. That is a specialty which I adopted many years ago and I continue to learn. I enjoyed it thoroughly. And this concept of autonomy, beneficence, non-maleficence, justice was introduced, as everybody knows, by Richard, by Bucham and Childress in 1994 on that. But the point I'm making is that autonomy is not absolute. And that is what I'd like to mention here.
Yes, sir.
Autonomy is not absolute. It is culture related. And you mentioned about culture and values. Very important aspect in the educational activities, at least in the UK at the moment, is that of all the 26 courses that all of us have to go through every year for appraisal, one of them is on work ethics. And in work ethics, diversity plays a very important role. And in diversity, you talk about racial discrimination, all these things that are happening these days, you have to accept them. And the other thing that I like to mention is that it's so autonomy, like I mentioned earlier on, a moment ago, that autonomy is not absolute. So in diversity, you have to accept different cultures, different values, different races. The important point I'm making is that autonomy in the Western countries takes the priority over beneficence, non-maleficence, and justice. But in the Eastern cultures, we have surrogate culture. Our leaders, our family heads, our clannish, the chief, the chieftain, you would call, is the chief of the clan. They take the decision in our weddings, many marriages, and all cultural activities. It is the head of the family who take. So surrogacy and surrogate consent is accepted in the Eastern culture, and autonomy is second to beneficence. And
Yes.
beneficence is top priority under all conditions, because the whole objective of all education activities, including interprofessional education, is to provide the best possible care to the patient, avoiding harm. One final thing that you beautifully defined, the concept of justice, and you identified 2 aspects of justice, which is fantastic. That justice is not just equality. Equality is distribution of everything to everybody. More important is equity. That equity means, and the simple things, the Arabic translation, as I understand, is equality is masawat, masawat. Equity is mawasat. And there's a difference. Equity means if somebody needs food, then you give him food. If somebody needs, the other person needs a shelter, you give him the shelter. So you distribute the resources according to your availability and the availability of resources and the needs of the community. So equity is more important than equality. That's a very subtle difference. Justice, and this is where I'd like to close, that John Rawls' theory of social contract, equal level playing fields, etc., is absolutely wonderful for all health professionals to learn. That you provide your service as best as possible to the best of your competency, etc., but also depending on the needs of the person. Needs of the person. That is where the important thing is. I thoroughly enjoyed the discussion. It's been a wonderful podcast. Final word from Nirmala and Anuja before we close the session.
So,
Ma'am, I'm waiting for your final words.
no. Final word will be from Anuja, sir, because she is specialized in this RP. Yes, Anuja.
I thoroughly enjoyed her talk about tracheostomy. Tracheostomy is not an easy thing. It has to be interprofessional. I've been stuck in my life many times when I had no support, nobody, and to do a tracheostomy in the middle of the night in ICU in the UK when there's only one anesthetist, not even a nurse. I tell you, it's a nightmare.
Yes, Anuja.
Thank you, ma'am. And thank you, sir, for your kind words. And thank you, Gohar, sir. You made the discussion absolutely enlightening. And I think the only thing that we would like to conclude this is not the conclusion. We are going on a new beginning with, from, and about each other as we take on to the journey of interprofessional collaborative practice. Thank you, ladies and gentlemen, for your time.
Thank you all.
Bye-bye.
Bye.